So we're going to talk about CMR, and Jagat challenged me to answer the question, will it ever become the go-to test? So these are my disclosures. So I'm going to split the talk into two parts. Well, I want to answer the question, will it become the go-to test in ischemic heart disease? And I want to say hopefully. And will it become the go-to test for assessment of non-ischemic cardiomyopathies and heart failure? It already is. So when we talk about the use of CMR in ischemic heart disease, we'll talk about the use to assess structure and function, viability, as well as vasodilator stress perfusion. Remember that we still don't give gadolinium to patients with a GFR less than 30 because of concerns about risk of nephrogenic systemic fibrosis, although with the newer cyclic agents, that disease has essentially is not seen anymore. We used to think that cardiac devices were a contraindication to CMR, but that is no longer the case. We safely image patients with basically devices placed after the year 2000, pacers, ICDs, et cetera, can be done safely in the right situation. They're interrogated before and after with proper monitoring during the study. I'll talk more about the limitations of CMR on a subsequent slide. So this is the standard functional imaging we do at present. Steady state free precession on the left is let me start the movie again, if I can find the, apologies. It's 2-chamber long axis, 4-chamber long axis in a patient with an apical wall motion abnormality and a small apical thrombus. So outstanding image quality, contrast to noise between the myocardium and the blood pool. We can also assess RV size and function either with axial imaging as shown on the left or short axis imaging as shown on the right. The volumes you get are similar. Suffice it to say that MR has become the gold standard for measuring both LV and RV size and function with cardiovascular imaging in 2019. A major advance of CMR over the last couple of decades has been the ability to image scar in the heart. How do we do that? We use a technique called inversion recovery, where we turn off the signal from normal myocardium. So we infuse gadolinium, and between 10 and 20 minutes after infusing gadolinium, we image, and areas of fibrosis or scar, in this case, this patient with infralateral 50% transmural infarction, light up with gadolinium. And why is that? There are two reasons. One is that there's increased volume of distribution for the gadolinium in collagenous scar, and secondly, there's delayed washout of the gadolinium. So any fibrosis, any scar appears bright. In this case, this is an MI. So it's the most accurate way of identifying and sizing myocardial infarction we have at present. Because of the spatial resolution of CMR, which is superior to other older imaging modalities, we can assess the transmurality of infarction on a segmental level. For example, in this segment, the transmurality is area A over area A plus B, so one would say somewhere in the 30 to 40% range in terms of transmurality. Much more accurate than our former use of electrocardiography for assessing transmurality. And again, because of the increased spatial resolution, it's a more sensitive study for identifying myocardial infarction than SPECT. This is an older study that was done in both large animals and in patients, showing there were a number of patients where the SPECT was completely normal, but they had small, generally 1 to 25% transmural infarcts as shown on the CMR with late gadolinium enhancement. In fact, half of the segments with subendocardial infarction by CMR had a negative SPECT. So CMR is more sensitive for identifying small infarcts. Now, why might that be important? Well, that was shown in the Iceland study that was published in JAMA in 2012, nearly 1,000 elderly patients who were imaged, some of them had had a prior recognized myocardial infarction, so they'd had a MI clinically. And then there was another cohort, in fact, 91 out of the nearly 1,000 patients had a clinically recognized infarction, but another 157 patients, so 50% more than had recognized MI, actually had an MI that had been clinically silent. So in this elderly population, these MIs were identified by late gadolinium-enhanced TMR. And you can see that beginning about year 3 or 4 after the patient was recruited into the study, that the overall mortality probability actually were parallel between years 4 and 8 or 9, so that the risk of having an MI that was not clinically recognized but recognized by CMR was similar to the risk of the patient with the previously clinically recognized MI. So the power of imaging to identify small, non-clinically identified infarcts, but prognostically important in terms of the activity of the underlying coronary disease. The other use of late gadolinium enhancement is to assess the likelihood of recovery of function after revascularization or viability. So this was a landmark study published by Ray Kim and colleagues in New England Journal now almost 2 decades ago, looking at how different infarcts in patients with various transmuralities of infarction did in terms of recovery of function after revascularization. On the left is a patient with a transmural LAD territory infarct, shown here. In the center is a patient with a 50% transmural left circumflex territory infarct here in the infralateral wall. And on the right is a patient with a 1 to 25% transmural, so small, basal inferior myocardial infarction. This is a study of 50 patients imaged before and several months after revascularization. About a third of the segments were dysfunctional at baseline, and most of those segments had areas of late gadolinium enhancement. So the graph at the right is an important concept to grasp here, and that is the inverse relationship between the transmurality of myocardial infarction and the likelihood of improved function after revascularization. If the infarct is more than 50% transmural, there's a very low likelihood of recovery of function. If there's no infarction in that dysfunctional territory and the patient's revascularized, there's about an 80% likelihood of recovery of function. Now, why isn't this 100%? Well, there are multiple reasons for that. There may be another underlying cardiomyopathy. It's not, perhaps ischemia is not the driver here. There might be tethering to infarcted segments. There might be incomplete revascularization. So even in segments with no prior infarct, there's about an 80% likelihood. These interesting segments that with subendocardial infarction between 1 and 50% transmural, their likelihood of recovery of function is between 40 and 60%, so not much better than a coin flip. We've done studies with low-dose dobutamine showing that in these segments, contractile reserve can do a better job at predicting recovery of function, but at the extremes, late gadolinium enhancement does very well, more than 50%, no recovery, no enhancement, very likely recovery. This meta-analysis done by Mario Garcia's group at Montefiore underscores the point I just made, that late gadolinium enhancement is quite sensitive, but the specificity is more modest. Low-dose dobutamine might be a little less sensitive than late gadolinium enhancement, but is much more specific. So the combination of anatomy and contractile reserve is probably ideal when the question is there going to be recovery of function after revascularization? I know it's a controversial area with the recent STITCH trial, but many of us still, and many surgeons and interventional colleagues still use assessment of viability to decide on revascularization. I turn now to the use of stress perfusion, CMR. How do we do it? We use another technique that turns off the signal in the left ventricle before the arrival of contrast. We give a vasodilator stress, either adenosine or regadenosine, and image the first pass of contrast for about 50 to 60 beats after the infusion of contrast. And then 10 minutes later, we will infuse contrast and image the same 3 slices at rest, so base, mid, and apex. You can see at rest that there's homogeneous uptake of the contrast here, light gray myocardium, but at rest and at stress in this individual patient, there's extensive ischemia here in the inferior wall, the lateral wall, and the mid-slice, the anterolateral, the infralateral wall, same regions at the apex, and this patient was subsequently shown to have 2-vessel disease in the LAD and circumflex. The accuracy of stress myocardial perfusion imaging with first pass CMR is quite high, as shown in this single center study from Duke. Typically we and they and most who do CMR combine the information you get from late gadolinium enhancement and the perfusion imaging to understand whether the patient has underlying coronary disease. So the algorithm that the Duke group proposed is to assess the late gadolinium enhanced CMR. If there's an infarct there in a coronary distribution, the patient clearly has underlying CAD. If they don't, you examine the stress perfusion images and rest perfusion images. If there's a stress defect but normal rest, the patient has coronary disease. The beauty of CMR is that we don't generally have many fewer false positive stress perfusion studies, because we don't, unlike SPECT, where there's a fixed defect, we can actually image the myocardial infarction that is or is not present underlying. So for example, here's a patient at the bottom. Well, let's start with the patient at the top. They have a clear-cut circumflex territory infarct, normal stress and rest perfusion. They had a prior infarct on an intermediate marginal branch stenosis, but don't have ongoing ischemia. The middle patient, there's no prior infarct. There's a clear-cut stress defect with a normal rest perfusion, tight LAD stenosis. This third patient, no prior infarct, what might be a stress defect seen here, but if you look at rest, there appears to be a similar appearing defect, but it can't be a coronary disease because there's no infarction, so you can't explain a stress and rest defect, so it must be artifact, and indeed this patient had a normal LAD. So one can use the late gadolinium enhanced imaging to exclude false positives. So our standard clinical stress exam in ischemic heart disease takes about 35 to 40 minutes. We do scout imaging. We start with 3-slice base, mid, and apex adenosine or regadenosine stress perfusion imaging. While we're waiting for our rest perfusion, we perform our short axis Cine images for LV function. We perform rest perfusion. Many labs now feel they don't need rest perfusion, that stress perfusion is good enough. And then in the last 5 to 10 minutes after the gadolinium's had time to settle in the myocardium, we do late gadolinium enhancement. Again, a stress CMR should take a full complete exam, no more than 35 to 40 minutes. So I shared with you single center data. Here's another single center study, but as Jagat alluded to, there's emerging very strong multi-center data about the powerful prognostic information from stress CMR. So this is single center data from Leeds called the CE MARC study, published a number of years ago in Lancet. A large study, 752 patients, about 39% had coronary disease. It was compared to SPECT. The gold standard was more than a 50% stenosis on QCA. FFR was not used in this study as the gold standard. They did use late gadolinium enhancement as well as part of their diagnostic algorithm, as I spoke of earlier. And you can see that no matter how you look at the patients, the blue curves are CMR, the red curves are SPECT, that the area under the receiver operating characteristic curves are higher for CMR as compared to SPECT, no matter how you look at the data. So that brings us to MR Inform, and Jagat, in one of his slides, challenged us to say, well, could you cut down on revascularizations using a non-invasive approach. He suggested that you could use FFRCT. Based on the MR-INFORM trial, which was published just a couple months ago in New England Journal, I will submit that you could do the same with stress cardiac MR and avoid the radiation and iodinated contrast dye of CT. So this is a large study, a multi-center study, nearly 1,000 patients. Half of them went with, and it was suspected coronary disease. Half of them went directly to the cath lab and underwent angiography and invasive FFR. The other half, so-called MR-informed group, underwent first-pass contrast-enhanced stress CMR and late gadolinium enhancement, and then only went to cath for a positive study. The patients were well matched. It was primarily a male study, 73%, 72% in the other group. Is done primarily in Europe, a very heavily Caucasian group, similar numbers of diabetes, prior MI, known coronary disease, etc. So this is the FFR-informed group on the left. And so all went to cath, only went revascularized for an FFR less than 0.8. 44% of those patients got revascularized, 52% did not. In the MR-informed group, remember they went to MR and only went to cath for a positive MR, only 36% of the patients were revascularized, meaning that 62% did not. So highly statistically different rate of revascularization between the two groups. You can see there's about 10% fewer revascularizations in the MR-informed group. And the hard cardiovascular outcomes were absolutely identical. Superimposable. So one could use a CMR as a gatekeeper and only send the patients for revascularization with a positive CMR instead of sending all the patients to cath. And the outcomes were similar with fewer revascularizations in the MR group. This is at 1 year follow-up. Obviously, these patients are going to be followed longer, and we'll see how long-term follow-up compares in these two groups. So based on MR-INFORM, we think that cardiac MR is a great gatekeeper, that it can reduce the number of revascularizations. This is information put together by our group, a meta-analysis published in JACC a few years ago, nearly 12,000 patients, a third of whom had ischemia, less than a third had late gadolinium enhancement, showing the prognostic power of CMR for the combined outcome of cardiovascular death and non-fatal MI, about six-fold higher annualized event rate in the positive studies compared to the negative, and you can see the differences in the individual event rates here. And just this week in JACC, the SPINS study was published. This is a multi-center registry of stress cardiac MR, and you can see that when looking at the primary outcome, there's a stepwise increase in event rates if you go from patients with no ischemia or no late gadolinium enhancement to patients with either ischemia or late gadolinium enhancement to patients who have both ischemia and late gadolinium enhancement. So identifying prior infarction and ischemia by CMR are additive and predictive of adverse outcomes over long-term follow-up. So the question is, why, if CMR is so good, why isn't it used as much as it should be? Well, I will submit that it's really politics and economics and not the science here. The problems are several: scanner access, lack of trained readers. There are too few training programs in cardiac MR and in cardiology and radiology in the U.S. Reimbursement remains a problem. There's in many institutions, they're not ours, and there's a divide between cardiology and radiology, and that can limit the use of the test. And out in practice, there are competing interests with practices with echo machines and nuclear scanners in their SPECT machines in their offices. So that's going to drive use of imaging tests. So it's really more politics than economics. The stress CMR is used much more frequently in Europe than it is in the US because many of these issues have been solved there more than they have been here. Hopefully this will change in the ensuing decade. So in the last few minutes, I want to say where CMR is clearly the test of choice, and that is in assessment of non-ischemic cardiomyopathies. A couple words about additional techniques that we have at our disposal to assess cardiomyopathies, and this is called T1 mapping for measurement of the extracellular volume of the myocardium. So on the left is a patient with a myocardial infarction. If you biopsied their heart, you'd see extensive replacement fibrosis. Here's a patient with hypertensive heart disease. There's no visible late gadolinium enhancement, but if you biopsied their heart, you'd see this lacy interstitial fibrosis. So can we image that? Can we measure that? And the answer is yes. How do we do that? So we do it with gadolinium. I'll take you through the technique. On the left is a normal individual blood pool. On the left, normal myocardium here. On the bottom left is a patient with any cause of interstitial fibrosis, valvular disease, hypertensive disease, HCM. You can see the blood pool here, lacy interstitial fibrosis here. If you give gadolinium in a normal individual, there are a few molecules of gadolinium caught up in the interstitium. In the patient with fibrosis, there's much more gadolinium in the interstitium because of the increased volume of distribution. Gadolinium is a T1 shortening agent, meaning the T1 will be low, so we can measure the T1 of the myocardium both before and after contrast, and doing that, estimate the amount of interstitial space there is and actually measure as a percent of LV mass the extracellular volume. So this is go through a few cases here. This is a 25-year-old woman who works at a daycare center in a town not far from Charlottesville, came in with cardiogenic shock, initially EF less than 10, had some recovery, got off of pressors, and was sent for a CMR to make the diagnosis. You can see global left ventricular dysfunction. So we made some measurements with CMR using T1 and the T2 of the myocardium. Normal, and this is at 3 Tesla, her T1 was 200 milliseconds higher than normal. Her T2 was well past the normal range, which is 60. Hers was 72. The increased T1 and T2 imply myocardial edema and inflammation. Turns out she didn't have any late gadolinium enhancement, so no fibrosis, no scar. But the elevated T1 and T2 in the setting of her history and severe global LV dysfunction was diagnostic of myocarditis. Often in myocarditis, you can see late gadolinium enhancement as well. Not in her case, but in this study out of Germany a few years ago, they actually biopsied the LV in areas of late gadolinium enhancement in myocarditis, which is classically not like infarction. It's more midwall and subepicardium, and it turns out there was active inflammation there. So lateral wall often, subepicardial enhancement can be indicative of myocarditis. I was privileged to be part of the rewrite of the Lake Louise criteria for using CMR to diagnose myocarditis. It was published in JACC late last year. The criteria for making the diagnosis of myocarditis by CMR is the presence of edema, either increased T2 on imaging or what we call T2 mapping, which was the image I showed you on the patient I shared earlier, plus evidence of increased interstitial space, either increase in the native T1 or extracellular volume. Again, I showed you the increase in native T1 on our previous patient, or the presence of late gadolinium enhancement, along with there may be supportive criteria, either a pericardial effusion, regional or global hypokinesis. So basically, imaging evidence of edema and increased interstitial space are the sine qua non of myocarditis in the right clinical setting. What about patients who present with non-ischemic dilated cardiomyopathy? Well, it turns out about a quarter of them won't have, 3/4 will have no late gadolinium enhancement, but a quarter of them have this interesting midwall stripe of late gadolinium enhancement here in the basal septum. What does this mean? Well, as I'll share with you over the next few minutes, any scar of the heart is a marker of adverse prognosis. So what happens to these patients with this midwall stripe and non-ischemic dilated cardiomyopathy? This is a long-term outcome study from the Royal Brompton in the UK, 472 patients, showing that the presence of scar is a marker of all-cause mortality, cardiovascular mortality or transplantation, sudden cardiac death, aborted sudden cardiac death, heart failure death, hospitalization, or transplant. No matter how you cut it, scar in the heart is a marker of adverse outcome. Whether it's going to be a subsequent driver of the use of ICDs remains to be seen. Randomized studies are needed. There's one study ongoing called the CMR Guide study in Australia and New Zealand, which is looking at how the presence of scar in non-ischemic cardiomyopathies can drive the use of ICDs over and above ejection fraction. Turn now to hypertrophic cardiomyopathy, where CMR is a very, very important adjunct. I go back and forward here. This is a patient with severe asymmetric septal and apical HCM with normal thickness of their lateral wall. So with CMR, we can do many of the things that echo does. Let's go forward again. Measure LV mass volumes more accurately, assess the outflow tract gradient, maybe not as accurately as echo, assess mitral regurgitation. But what MR gets us over and above that is the imaging of scar. These are 6 different patients with HCM with different amounts and locations of scar in HCM. It turns out about half the patients with HCM have any scar. A study that I'm co-principal investigator of, along with Stefan Neubauer, has recruited 2,755 patients with HCM at 44 sites in North America and Europe, using standard clinical predictors as well as CMR, biomarkers, and genetics to do a better job of predicting outcome in HCM. I'm glad to say the data on the baseline patients from this study is now in press at JACC. Hopefully will be coming out. I just got the proofs by email this morning, so it should be out in the next few weeks. What we did with these 2,755 patients, notice there are 2 broad, relatively distinct populations. There's a group who are sarcomere mutation positive that more often have this reverse septal curvature form of HCM. They have more LGE and more interstitial fibrosis identified by T1 mapping, and it's quite likely that they have a different prognosis than the other population, which were sarcomere mutation negative. They more likely had isolated basal septal hypertrophy, less late gadolinium enhancement and interstitial fibrosis, and interestingly, more LVOT obstruction. The mean follow-up now is at 3 years. Longer follow-up is needed to assess which of these populations have different prognoses and whether we can alter therapy based on the imaging and genetics. Another patient I imaged last weekend presented with VT, and you have this severe biventricular dysfunction, unusual pattern of wall motion abnormalities, this basal anterior akinesis. EF was 17%. And on late gadolinium enhancement, it has this very specific form of LGE, subendocardial sparing, midwall and subepicardial LGE in the basal anterior wall, basal inferior wall, characteristic of myocardial sarcoidosis, which was subsequently proven based on chest CT and biopsy. He's on high-dose steroids and getting an ICD now. Our group has shown that the presence of LGE in this meta-analysis is associated with a 6-fold increase of the combined outcome of all-cause mortality and arrhythmogenic events, and a strong trend to an increase in all-cause mortality compared to those patients with sarcoid without LGE. Lastly, a patient with severe left ventricular hypertrophy, moderate to severe global systolic dysfunction. It appears that they have asymmetric septal hypertrophy, but that's a bit of a red herring, because it turns out they have this diffuse late gadolinium enhancement and inability to null a normal myocardium, which is characteristic of myocardial amyloidosis. There are 3 patterns of or a couple patterns of late gadolinium enhancement and amyloid that, and in this case, it's not fibrosis, it's replacement of the myocardium with beta-pleated sheets, and so increased volume of distribution for the gadolinium. The T1 and the ECV in these patients are incredibly high. The extracellular volume, because of the amyloid fibrils, is around 50% of the myocardium. In the prognosis, you can identify the more transmural, the late gadolinium enhancement in yellow, the worse the outcome over a 4 to 5 year follow-up. So in summary, in ischemic heart disease, we think that CMR, based on the MR-INFORM trial, is a go-to test, a terrific gatekeeper, keeping patients out of the cath lab and revascularizing only those who need it. Again, politics and economics has held it back. In terms of differentiating and assessing the prognosis of non-ischemic cardiomyopathies, I would submit that it's presently the gold standard technique. Thank you for your attention.